We can go ahead and start, Marcel. So you can go ahead and start. Thanks.
Hi, everyone. Can you hear me?
Yes. Yes, yes, you can.
Awesome. Wonderful. Yeah, hi, and greetings from Heidelberg, Germany. I just posted a link to my slides to the chat, so everyone can look at the links and on the figures, of course, by themselves. Yeah, hi, I'm Marcel Reinmuth. I'm with the Heidelberg Institute for Geoinformation Technology, sorry. And yeah, thank you for the opportunity to give this lightning talk on OpenStreetMap for healthcare access. So basically, I will show you two studies we've conducted using open data, open tools to estimate the state of health supply in countries and compare countries. We relied on OpenStreetMap data, extracting hospitals, and then we used two different methods to estimate the area from a hospital where you can reach in a certain amount of time. You can also refer to this as a catchment area. So we used a raster approach using the Access Mod tool and a graph or network-based approach using the Open Route Service isochrone service. And then we used these areas from each hospital and intersected it with population products from WorldPop. So here you can see the results for our first analysis using the network or isochrone approach. On the right side, you see a map of Senegal. You can read it like if you are in a green area here, if you're located anywhere in a green area, it takes you 0 to 10 minutes to the closest hospital by car, I have to say. If you're in a red area, it takes you 50 to 60 minutes to the next hospital. So again, we took these areas, intersected it with population, and then aggregated it per country for every country in sub-Saharan Africa. And on the left side, you see these results, again, aggregated by country, and so we can compare it. So you see, for instance, Burundi is performing very well. These numbers are the proportion of population reached. So Burundi reaches 94% of its population within 60 minutes, but again, by car. And we see Rwanda performs second, and we see countries as South Sudan or Equatorial Guinea don't perform as good. More details you can see behind the link at the bottom. There's a blog post with more details. This was this was our second case study using a raster-based approach. In our first study, we were constrained to 60 minutes. For this study, we had continuous travel times, also going further than 60 minutes. And we also published this in the Lancet Healthy Longevity. You'll find that paper on the link at the bottom. However, although we used a different approach here, raster approach, cost raster-based approach, we almost have the same results. We see also Burundi performs best. We also see Rwanda in the top 5, and we see Sudan, South Sudan, and Equatorial Guinea don't perform as good. So what were the challenges? Let's focus on the challenges of these two studies. Of course, quality of OpenStreetMap. We saw that Burundi performs as the best country. And if we look in more detail at Burundi and healthcare data in OpenStreetMap, we see more than 600 hospitals mapped in Burundi. And this is most likely due to misclassification. Probably most of these facilities are rather primary care units and not hospitals. We also see model uncertainties, of course. We took travel mode for like car driving, and this reflects probably not the average travel mode. So there are different travel modes needed, like walking or taxi buses. However, we showed with this analysis that we can only rely on open data and on open tools. We can give information on where our health supply sinks, for instance. And this is the cool thing about OpenStreetMap. We can run that in every country using the OpenStreetMap data model. And the data is improving. We just saw a talk by Mark Herringer from the Health Sites Project, who is advocating for better data and better quality. We see imports, a huge import going on in India right now, increasing by more than 30,000 data points, the healthcare objects there. And this is my last slide. I want to point to actually I just want to echoing what just Mark said about healthcare tags. We have more than 30,000 healthcare objects in sub-Saharan Africa. And here I have the frequency of different tags associated with these objects. For instance, we see the amenity tag, healthcare tag, name tag among those most prevalent. But how about other tags? Because if we just have amenity, okay, we know it's in a hospital or a clinic and we know the coordinates. But how about, is there an operation theater? Is there an X-ray? Or here at the bottom, the beds tag. I mean, we heard it in the news during the pandemic. How important is this information? What is the capacity of a certain facility? So for instance, the beds tag is only mapped by 1% of these objects in sub-Saharan Africa. And I think if we increase this data, if we increase these tags, we can improve our methods, we can improve our analysis and deliver more and better information for decision makers in public health planning. And with that, I want to end. Thank you for your attention. If you have any questions, reach out by email or via the chat. Thank you.
Thank you so much. Thank you so much, Marcel, for the presentation. So we'll just move to the next one. So the next session, we'll be playing the pre-recorded version for Deogratias Chigude, who is presenting on a project by Map Uganda on using drone technology for the OSM community in Uganda. But if you're interested in the other session, one thing to note is that the session is in French. So as you move to the other room, kindly take note of that. So this is the link to that session if you're interested in joining that. And then, so yeah, that will be it. So you can go ahead and listen to Deogratias. Yeah, just a